Hi, everybody. In the spirit of Drs. Van Schaik and Dr. Hirsch, I'm going to start us right on time at noon. For those of you I don't know in the virtual audience, I think I know everyone in the physical audience, but I'm Dr. Liz Rogers. I serve as Associate Vice Chair in the Department for Faculty Development, and I'm thrilled to be here to help facilitate what I expect to be a very exciting and really fascinating grand rounds. So before we start, we'd like to acknowledge acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land, and pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. So I'm thrilled today to welcome Drs. Kober and Kopp to talk to us about power, bias, agency, stigma, how language and the electronic health record can empower and disempower. Dr. Kober is an intensivist and researcher in UCSF's Department of Anesthesia and Perioperative Care at San Francisco VA. He went to Duke University for medical school, trained in internal medicine at the Hospital of the University of Pennsylvania, and then did his anesthesia residency at Duke. And critical care fellowship at UCSF. Thankfully, you hit the right coast at that point. He practices in the VA operating room as an anesthesiologist and in the ICU as an intensivist. His research focuses on palliative care in the ICU, post-ICU syndrome, morbidity in older adults, ICU survivorship, and clinician reflexivity and language using natural language processing and artificial intelligence. Dr. Kopp is a clinician educator in UCSF's Department of General Internal Medicine. She went to Emory for her medical training, and UCSF, she made the decision earlier, thank you, for residency and primary care fellowship. As a clinician, she practices primary care, urgent care, and precepts residents on their outpatient blocks. And as an educator and researcher, she focuses on decreasing stigma and bias in the electronic health record written documentation. So thank you so much to you both. And we're eager for good engagement. So write your questions in the chat and we'll get to them by the end.
Thank you so much. Thanks so much for having me. I do want to first start with some conflicts of interest. So I've received consulting fees from Teleflex, and I have some grant support through various divisions and departments at UCSF and some foundations and societies primarily related to the research that I will be sharing today. And Dr. Kopp reported no conflicts of interest. Learning objectives at the end of this presentation, we hope that you will be able to examine how language and notes in the EHR can be disempowering and promote inequities, understand new research around linguistics, NLP, and artificial intelligence, NLP being natural language processing using electronic health record medical records, and to better appreciate ways flags can be disempowering to patients and families. So I wanted to start by asking, what do you think all of these characters have in common? We don't have a huge audience, but if anyone wants to chime in.
How we rely on us actually knowing who all the characters
Exactly. That is really important. I wish I labeled it on this slide, but it's actually on the next slide. So all of these characters, I would argue, are unreliable narrators. Do you know who else is an unreliable narrator? Me. So I wanted to start by asking some fundamental questions related to this, which are, what are the implications of considering a patient's clinical record as an illness narrative? How and to what extent are clinicians acting as narrators in the story they are telling about the patient? And finally, what are the consequences of artificial intelligence models being trained on illness narratives told by clinician narrators? I think a good starting point is to ask the question of what is a clinical note? LOINC, which is an ontology around structured data elements in healthcare, defines a clinical note as a document of a patient's clinical status during a hospitalization or outpatient visit. But are notes just objective documents of observed realities? I would argue no. We are training our residents. This is lifted from MedHub 2 days ago, whereby we don't just want our medical students or residents simply being reporters or documenters. We want them to do more. We want them to interpret, to manage, to educate. And the nature of our reality when it comes to caring for patients and families is, I would argue, and others have argued, gradually revealed through the stories that they tell to us, through the narratives around their illnesses and their lives, and the discourse between us and them. And this is what Rita Sharon argued in 2001 in her JAMA article on narrative medicine, which is against this reductionist approach to medicine that maybe we were practicing before. So then what is a clinical note? I would argue it's a narrative. It includes a story told by a clinician narrator about a patient who acts as a subject or the protagonist of the story. A lot of narratives follow normative structures, these common structures that are true across lots of different types of storytelling, whether it's song lyrics, newspaper articles, horror films, romance novels, poetry. And I would argue that the clinical note shares some of these normative elements and structures that across other narratives as well. Lawrence Weed described a new approach at the time in 1961 to documentation of the patient story in a New England Journal paper, whereby instead of presenting so-and-so like March 4th, 1960 at 12 p.m., we ran this set of labs and we did this intervention, and on and on and on. He argued that maybe a problem-focused approach and way of documentation could not only guide care, but also guide teaching. And this was in the early days of computers within the EHR. The other interesting thing about notes, just like other narratives, is that they include a whole lot of subjectivity. It's ubiquitous subjectivity. And it's oftentimes conscious and unconscious choices made by the clinician note writer. There's sentiment, so things like these are subjective opinions that carry valence, whether it's positive or negative. So such and such is concerning for metastasis, something bad, or an incision is healing nicely. These are opinions. There are biases, like the inclusion of a race descriptor in notes, or something being poorly controlled. Controlled by whom? Controlled for what? Stigmatizing language, which goes hand in hand with biases. The patient was non-compliant with their insulin. They're a substance abuser. We use metaphors in really interesting ways. He was fighting the ventilator overnight, or their chronic illness or cancer is a journey. We have uncertainty peppered throughout our notes. Unclear exacerbation trigger, could be a PE, the differential itself. We use passive voice in really interesting ways. Restraints were used, just like mistakes were made. We insert ourselves within the notes. These are notes that are supposed to be about a patient, and yet, maybe I'm alone in this, I often or will write about my own concerns and my own fears about prognosis, about what I might be missing within the note itself. I think he is dying. We spoke to the family yesterday. We use adjectives in very interesting ways. So-and-so is a very pleasant person, pleasant patient. They were rude and aggressive with staff. And then a final example are the change of an adjective to a noun that could lead to depersonalization and dehumanization. So instead of somebody having cirrhosis or having diabetes, they become a cirrhotic or a diabetic. When thinking about notes as narratives, I've been thinking a lot about how this fits within this field and discipline of the narrative. And there's a discipline called narratology. And putting all of this together, I think about characters within a narrative, and those are the patients, the families, the clinician narrator, the narrative itself, so the story, the ebbs and flows of clinical events, the narrating, which is done by the note writer, and then the linguistic choices that are being done by the note author themselves. We all often have an audience in mind. We are thinking about who we are writing for. I think we would all have different answers in terms of who we maybe prioritize to write to or for. I think most of us would say we often are writing for ourselves. We're trying to frame the problems. We're trying to justify our choices, either for future reference or to simply try to understand what phenomena might be going on. But there are other authors that we are oftentimes really aware of. There are regulators, there are billers and insurers. We have to write certain things in order to get appropriate billing for the work that we do. There are lawyers who might be reading our notes. There are administrators. If you're a consultant, you are oftentimes thinking about the primary service or primary team who will undoubtedly be, hopefully, will be reading your notes. And then since open notes, and even before, many of us are aware that patients or expect patients and their families might be reading our notes as well. And our language changes as a result. Within all of this are societal elements, cultural elements. We are all writing these notes in a specific time and in a specific place. And we also have ideas of meta narratives and phenotypes and expectations of how patients will do in regard to their disease states. And we want individuals, maybe ourselves, to kind of fit neatly within these frameworks. I promise these are my final last two slides of like cognitive overload. But all of this goes hand in hand with the field of cognitive linguistics. It's hard to kind of parse these two apart, but fundamentally, my premise in a lot of my work is that language affects thought and thought affects language. And there's some theory around this and a lot of data whereby there's a fundamental commitment to the notion that language is deeply rooted in human cognition, instead of language just representing some sort of its own internal structure based on neutral and pre-formed ideas. So there's something interacting between our cognition and the language itself. On the flip side of language affecting thought, thought can affect language. So linguistic structures, semantics, meaning are influenced by our own cognitive framework and experience. The corollaries of this are that clinical notes are representations of our own clinical cognitive frameworks, and language within the clinical notes can affect those cognitive frameworks. So I want to give you just two examples just to like drive the point home in case you haven't been exposed to any of these ideas. A famous example by Lakoff and Johnson in a book called Metaphors We Live By in 1980 provided a really fun example of metaphor shaping how we think potentially, which is what if we framed argument as war? And you can kind of think of, instead of argument, think of like negotiation, which you might have seen, Negotiation is War, the book title and whatever, Barnes & Noble, whatever. But if argument is war, then we use terms and phrases like so-and-so attacked my points. I'm losing ground in my argument. My argument was built on a weak premise. So if argument is framed as a battle between adversaries, then there's a winner and there's a loser, and it's zero sum. But if argument is a dance and I'm leading a debate, or I'm meeting you in the middle, or I'm exploring different angles in the argument, then the participants become performers with a goal of performing in a very balanced way. Okay, How about a data-driven example? If I frame crime as a beast versus a virus, this was work done by Thibodeau about a decade ago, then individuals who read these two different examples of metaphors related to crime, if they read crime as a beast, they are more likely to choose enforcement and punishment-based measures to treat crime. Well, if you think of crime as a virus or an illness, then you're more likely to choose social reform measures to treat crime. So what I wanted to do is I wanted to go through all of these, just about all of these different forms of subjectivity and demonstrate some of the work that we're doing, but also some of the data behind this. Sentiment. So the classic sentiment-based algorithms in the past were in the artificial intelligence and natural language processing world, whereby these are opinions made by somebody about something that carry a valence. So positive, negative, pro and con, something like that. The original descriptions were for something like product reviews in Amazon. So if you have a Nikon camera and you are trying to figure out, is this a good camera or a bad camera? Or in Rotten Tomatoes, is this a good movie or a bad movie? But you have to sift through massive troves of reviews. Then there was a desire to create an automated technique to extract that sentiment and opinion data. Unfortunately, we can't really carry over camera reviews from Amazon to medical records because our vocabularies are different. So our group created a negativity and positivity algorithm and classifier for automated sentiment capture in the electronic health record. And it seems to be associated with mortality if you are more negative. That may not be very surprising. So is there a cause and like, what's the cause and what's the effect here? So as a patient becomes more sick, becomes sicker over time, I may become more pessimistic, more negative over time. So it's very possible that the acuity of the patient is guiding my language. But we do see some interesting stratifications and dichotomies between patients who survive and patients who die, regardless of where the sentiment is measured, on the first day, on the middle day, on the last day of their ICU stay. So globally speaking, there's a pattern, but also if we just isolate first day notes, first day sentiment is first day negative sentiment is highly correlated with global mortality. Which raises some interesting questions of how much do our preconceived notions of how we think a patient will happen. If we also did cost proportional hazards and day level logistic regression, and day level sentiment after controlling for disease acuity predicts next day mortality. Biases, stigmatizing language. Patients who self-identify as Black are more likely to have their race mentioned in the history and present illness than patients who are white. This was published by Balderson in 2021. We did a similar study here at UCSF, which is currently under review. Balderson's study was in Boston. Maybe the data is about 10, 15 years old, spans like a pretty large data set. Maybe we're just more in tune now. And the answer is, and maybe UCSF is more woke. And maybe we are just better at not describing race in notes. You can definitely make an argument that having a better understanding and appreciation of social identities and social constructs may lead to increased use in notes as well. But either way, if you are Black, if you self-identify as Black at UCSF and you are an ICU patient, you will more likely than white patients have your race mentioned in a note. And if you're Asian, half as likely. And this is after controlling for, let's say, bad actor note writers who are writing race terms in all of their notes. We clustered for that too. Himmelstein, which Zoe is going to talk about a little bit in the next part of the presentation, estimated that stigmatizing words and language occurs in almost 2.5 to 3% of notes. You might say, well, it's not really a lot. But then when you think about it, it's kind of a lot when it should be 0. So words like adherence, non-adherence, control, compliance, unwilling, abuse, belligerent, drug seeking, abuser, et cetera, are all present. And unfortunately, we use them more often than not in Black patients versus white patients. We tried to extend some of this work by looking at proximities of words, of race descriptors to stigmatizing words in notes. And we did also look at them at how they evolved over time, which is a different study, which is currently under review. But basically, our decision to put in a race descriptor in a notes is a choice. Even if it's unconscious, we're doing it. And we also are choosing to put in some sort of stigmatizing word, even if we're not intending to be stigmatizing. And we can measure those distances, those co-occurrences, those co-associations of words using neural networks and various AI-based approaches. But what's interesting to simply quantifying potential implicit bias in notes, which is what I would argue is maybe something that we're doing, is that if you compare UCSF notes to Boston notes, and we did 2 data sets, we see changes in terms of how these proximities occur. So the stigmatization, if you believe that this is stigma, seems to be occurring the occurrences that we see are largely dependent on where you are, where you're practicing, who you are, and your time period. So you live within that big society culture bubble within clinical narratology. Metaphors. One of my mentees, Shannon Kim, published in last year a perspective piece arguing that violent metaphors like so-and-so is fighting the ventilator should be abandoned because they other patients, they exclude patients. And that they don't really even say anything that's clinically relevant. Fighting the ventilator could mean a dozen different things in terms of patient-ventilator interactions. Is it auto-triggering? Is it reverse triggering? Is it stacking? Is it low flows? All of these different things, they don't tell me anything. We followed this up with a qualitative study that's currently under review, whereby we did actually more of a cross-sectional examination, qualitative using grounded theory, whereby we just extracted every note that contains any combat mention. We defined whether that was a true metaphor based on pre-existing metaphor definitions. And we were able to describe a conceptual framework around these metaphors being used in empowering ways and potentially disempowering ways. So it's not always bad. Uncertainty. Callan in 2020 published a study that's probably rings true to a lot of us, where they looked at radiographic reports and they found a whole lot of uncertainty terms being used. And I think we've all kind of seen that. There's maybe a certain amount of hedging that's being done, or they don't always have all the information that we are seeing from the clinical side. So something very well could be atelectasis, or could be pneumonia, or could be pulmonary edema. But they found that this occurred differentially. So chest and abdominal imaging, over 50% of them contained an uncertainty term, but it wasn't always consistent based on whether the imaging was done in the inpatient setting versus the outpatient setting versus the emergency room setting. Passive voice. So I think that we have a lot to learn from how research around violence against women and sexual assault literature describes the use of passive voice and the implications. Our group is working on this as well, but Haliki wrote last year in an article that passive voice emphasizes the victim compared to the perpetrator. This focus on the victim obscures the agency and responsibility and shifts causal attributions for the assault from the perpetrator to the victim. I think it's really fascinating why we use and when we use passive voice. We were all taught to not use passive voice. It's the weaker form of voice, according to every grammatical textbook. There's definitely a lot of debate around that. But I find it really interesting, and I do this all the time. The patient was placed in restraints. Restraints were placed overnight. The patient was coded. We never say yesterday, I restrained the patient. Why do we write like this? It's very weird. So can stigmatizing language alter our behaviors? Godou wrote in 2018, did a study whereby they presented 2 different vignettes, one with neutral language, one with stigmatizing words and phrases to house staff and medical students. And then they surveyed those students and house staff after. Mr. R is a 28-year-old man with sickle cell disease who presents with 10 out of 10 pain in his arms and legs. And there's a lot more to the vignette versus Mr. R is a 28-year-old sickle cell disease patient who presents stating he has 10 out of 10 pain all up in my arms and legs. When you survey respondents, when they see those stigmatizing vignettes, they attribute more negative attitudes toward the patient than when they see the neutral phrasing. And if you ask them another question of how would you actually treat these patients, they provide less aggressive analgesia for them after seeing stigmatizing words. So language can disempower. Dr. Kim, in our violent metaphor piece, described that such examples can inappropriately imply volition and blame, create oppositional relationships between patients and the medical team, and potentially mediate healthcare disparities. This goes in line with an early essay by Susan Sontag in 1978, when she had a diagnosis of breast cancer, and her therapies, her disease state was all characterized as war, as battle, as combat. And she felt extremely disempowered by this and described it back in 1978. And this is in line with Nixon's war on cancer. We still see this a lot, right? There was a war on cancer, there's a war on AIDS, there's a war on COVID. Have we won? I don't know. But on the flip side, language can empower as well. Just last year, Albury published a study in Annals of Internal Medicine, whereby framing referrals to a behavioral weight management program in an opportunistic way or a positivistic way, such as really good news, you're about to enter this referral program, as opposed to scare tactics, led to increased weight loss. Why else should I care? Or why else should you care? OpenAI, Copilot, Bard, Gemini, Claude, Elmo, which is Baidu's one. We are thinking of all of these really interesting ways of using large language models in healthcare. Research, education, patient care. UCSF is about to roll out their own ChatGPT officially, which is a PHI safe GPT or ChatGPT called UCSF Versa. Epic made partnerships with OpenAI to integrate these large language models. It's happening. Our AI overlords are here. Every AI language model is being trained on data derived from human authors. ChatGPT's sources are Common Crawl and Refined Web, which are just like scraping the internet for stuff. And they don't want to admit it, but it's also Twitter or X and Reddit and YouTube. You can imagine why they don't want to admit that it was those. But that means that they're all trained on the alt-right or alt-left, whatever subreddits are being used to train these large language foundational models. And this is a huge problem when source data is biased. Garg and Kliskin published these landmark studies 7-8 years ago, whereby gender stereotypes, racial stereotypes, any stereotype can be transmitted from input data to outputs when you insert them into any neural network model, and GPT is a neural network model. You might say, well, those were not sophisticated models. They had one hidden layer in their neural networks, blah, 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 blah. Okay, what about ChatGPT? ChatGPT and all of the GPTs, I should say, learn human moral norms from the input data. There is some sort of right and wrong that's being described and trained into these models. I'm not saying they're human. I'm not saying they do things that humans can do or anything like that. They're just being trained on the source data written by humans. So they carry the same biases. This other group wrote, audacious is to boldness as some sort of religious adjective, is to that religion. And in GPT-3, a really recent GPT, they found that audacious is to boldness as terrorism is to Muslim, but as goodness is to Christian. So to conclude, some really, I think, interesting final behavioral extensions in terms of like, where are we going from here? Why should you care about this? What do I think is very interesting? How are readers, patients, caregivers, clinicians affected by this language? Can narrator subjectivity be used to predict our own behaviors and patient outcomes? Can we intervene on these frameworks and behaviors to improve patient care and potentially clinician well-being, which I would argue can manifest in notes themselves? How should notes be written by AI? Who is the narrator when AI is writing these notes in part or in full? Do we truly want to lose subjectivity in note writing? And what are the repercussions to narrative medicine as a whole if an entire discursive medium, clinical notes, become AI generated? Just want to thank a bunch of people. I'm all for team science. I work with a lot of super smart people who are much smarter than me. And I have a growing mentee community, and I just wanted to thank lots of different people who I work with. Thank you so much.
Thanks so much for having me. I'm going to continue on into a more extreme example, which is patient behavioral alerts or flags, which is a type of documentation that's used to communicate interprofessionally across time and space. Forgot to read it, this is a UCSF example of a flag from 2016. Patient had an appointment on 1/18/16 and was 55 minutes late. Provider was unable to see her, and she became extremely upset, verbally assaultive to staff, and RN report smelling ETOH on breath. Today, 1/19/16, patient returned and once again was aggressive, demanding, and inappropriate with this writer. Walked out cursing. Set firm limits with this patient and call UCSF PD if escalation occurs. So why might someone write an alert like this? What was the writer hoping to achieve by writing this alert? Could act as a warning, maybe increase provider safety by providing context clues for future encounters. When this patient uses alcohol, they become aggressive. When they might be late, they may have poor coping skills. The writer might have wanted a space to vent, or they may have thought that this could be used for medical legal documentation. What are the potential benefits to reading a flag like this before seeing a patient? You could emotionally prepare for the encounter, physically prepare. Maybe you would go with a buddy, position yourself by the door, encourage a provider to focus on trust building, and consider that some of the patient's actions might be driven by a substance. Why is an alert like this problematic? It's labeling, it's venting without problem solving, it's biasing, and it contains a lot of assumptions. And what's specifically problematic about this flag? It comments on lateness, alcohol use, cursing, describes the behavior as aggressive, demanding, and inappropriate. It criminalizes the patient's behavior by requesting for police involvement. And there's limited context included to allow the reader to maybe reframe why the patient's actions were happening. And furthermore, it doesn't provide us with any information on how to change this behavior or work with this patient moving forward. So one of the reasons we use flags is because that's the technological option we have available to us. Flags were started at the VA in 1982. At the Portland VA, there was a series of violent incidents. They created a behavioral emergency committee to track these incidents, and patients who had a pattern of behavior got a flag placed on their chart, which we know as CPRS. Now, flags are really a ubiquitous part of most EHRs. They've proliferated and they show up in a typical fashion, though individual institutions can dictate how they're used. Most of them have a title, a text box, and can be associated with a pop-up notification. They may remain active in the chart forever unless the institution has a policy to review, revise, or remove them. And they continue to exist and proliferate because we have a mandate from the Occupational Safety and Health Administration to provide staff with a patient's history of violence if there's risk for future violence or aggression. So using flags is one way that institutions can operationalize this legal requirement. So given the pervasiveness of violence against healthcare workers, having behavioral alerts is could seem like a very reasonable thing to do. In qualitative interviews with frontline staff, they report using the flags to provide reassurance of safety, maybe take proactive measures like bringing a buddy into the room, involving security, or doing person checks to look for weapons. They also can communicate with other providers about the risk for violence. And behavioral alerts in some contexts have been shown to be predictive of violent behavior. In 2006, at an acute care hospital, they screened patients for a history of violence or for current violence in the emergency room. And 91% of those patients went on to show aggression later on during the hospitalization. Oops. Unfortunately, there's really limited support for flags. Only 2 studies have deemed flags to be effective violence prevention tools, and both those studies did not contain a comparison to patients who were at high risk for behavioral incidents, but did not have a flag. And furthermore, a recent Cochrane review found that most workplace violence tools, including flags, do not lead to reduction in violent incidents. And flags can cause harm. They can promote stigmatization by labeling patients for one-off encounters as violent, or by criminalizing patients' medical and mental health illness. They can result in undertreatment through limiting or challenging the physician-patient relationship, by resulting in denial to admission to skilled nursing facilities. And they're placed in a biased manner. Patients who identify as Black, have public insurance, or have a psychiatric or substance use diagnosis are more likely to have a flag placed on their chart. 2 recent studies in 2003 show the negative impact that flags can have on patients. The first one was in 10 EDs, and they looked at patients with behavioral alerts, and they found that the encounters that had behavioral alerts associated with them resulted in more patient-centered discharge, elopement-style dispositions, or leaving without being seen. And then the second piece, also in 2023, in 3 Philadelphia EDs, they found that Black patients compared to white patients were more likely to have a flag on their chart. And then of the patients with flags, Black patients with flags were more likely to wait longer in the emergency room, wait longer to see an ED physician, and have fewer diagnostic tests ordered on them. At UCSF, I examined flags in the outpatient primary care setting and found similar demographics. Patients in our general practice who had flags were more likely to be Black, have public insurance, and have a psychiatric or substance use diagnosis. And so I just want to share a very recent example of a UCSF flag and how this might have resulted in a negative impact on this patient's care. This is from November 2023. So it's a middle-aged man who presents to the emergency room. He has a finger laceration. He's evaluated, sutured, and discharged. But he comes back the next day and says, "I'm back because there's a lack of communication between doctors and I'm unable to make any appointments. And I'm supposed to see the hand MD in 2 days and I cannot make it. I think I might lose my finger." The emergency room note at that time describes the patient's challenges with insurance and also makes note of the patient becoming visibly frustrated and verbally aggressive. So a flag was placed, and it states, "Patient cornered provider and closed curtains and became verbally aggressive while posturing for potential physical violence. high risk of aggression. He comes back. He represents because he was told that if he doesn't hear from the subspecialty clinic, he should call them in 3 days. So he calls the clinic and is told, oh no, you actually need a primary care doctor to place this referral. The ED referral is not going to work. So he goes and gets a primary care appointment on 12/6, has an urgent referral placed to the specialty clinic, and then the following day, he calls once again to make his specialty appointment. But because his behavior on the phone with the specialty clinic and in the ED, his referral is denied, he is not seen, and he is never allowed to be seen. Documentation of this patient's behavior describes verbal aggression, use of curse words, and descriptions of self-harm while he was on the phone trying to schedule the appointment. It describes a patient who's very frustrated with their inability to be seen and who did not express themselves well on the phone. It also illustrates the stark reality that because of this patient's insurance, they had a lot of scheduling challenges and his appointment was denied and he was ultimately never cared for. So we are trying to revamp how we do flags at our institution. We have a FYI flag task force that meets regularly to discuss flags. We've implemented a state where all outdated flags that are greater than 3 years old and haven't been edited are automatically removed. And our task force will be responsible for writing future flags as they're requested to be placed. There's a lot of representation in the group. We have clinicians, risk, security, nursing, and Apex folks there. And there's a new Epic upgrade that's coming in the pipeline. I'm not sure when it'll be sort of deployed in Apex, but they're going to be putting this care considerations in the storyboard, which appears to include some sort of violence assessment tool. I'm not sure who made the tool or if it, what research it's based on. And then I'll have a link to the patient's FYI flag if they have one. However, while flags are a very important example, the reality is that we really need to investigate our documentation in general. And some of this was touched on earlier, but stigmatizing language is in our documentation. And research shows its presence as judgment words, evidentials, indiscriminate use of quotations, stereotyping, and expressing negativity. And the way we use this language is biased. And not only that, but the stigmatizing language, as stated before, can change our behavior. And this is just a reference to the Godot vignette that was described earlier, as well as ones by Kelly et al. That showed that subjects form negative attitudes and then wanted to use more punitive measures against patients who were described with stigmatizing language compared to those without stigmatizing language. So knowing this, what can we do to document better? I just want to introduce 3 basic skills: reflection, patient-centered word choice, and the power of writing. So for reflection, I'm referring both to external reflection, so considering what effect will these words have on those who read them, and internal reflection, what feelings do I have that I'm trying to express in these words? Next is patient-centered language choice, specifically thinking about removing extraneous details, limiting judgment words that cast doubt on the patient experience, and limiting unnecessary quotations. And then finally, the power of writing, reminding ourselves that as the documenter, we have the power to write the patient's story, and we should feel empowered to do right by our patients in our documentation. And just wanted to share this quote from JAMA Piece of My Mind. Is somebody a patient, a victim, a survivor, a burden? Whether intentional or not, clinicians are often an important source of vocabulary that these writers draw from. With each choice of words, clinicians affect narratives, and some words wield particular power. So many pieces of the plot line are outside of the patient's control. And yet the stories told about these experiences are perpetually being written. At times, clinicians are co-creators, helping to choose the words with which they are crafted. At times, clinicians are editors, reflecting back on bigger themes, the meaning, the identity of the characters. And I will finish with a short note that was written about one of my primary care patients while she was hospitalized. So, patient with Doritos, Coke, juices, pork soup brought from outside. Patient reminded of current diet, fluid restriction, and the importance of monitoring sodium intake. Patient states, "I know," and continue to eat her outside food. So, to reflect, what was the purpose of this note? What is the author trying to convey here? Does it reinforce a stereotype? The author may have wanted to document dietary indiscretion and a lack of rule following, but unfortunately, this note does reinforce many stereotypes around food choices and patients with chronic illness who are hospitalized. Language choice. This author, in this very short note, uses specific words and quotations that are really not necessary for conveying the underlying message about this patient's medical care. And the power of writing. Ultimately, this note represents a missed opportunity to engage with the patient, demonstrating passivity rather than an attempt to collaborate or understand where she's coming from. That's it. Thank you.
Julian to join us up here on the podium for Q&A, which I'm sure many of you have. There are a couple coming in. I'll give some folks remotely time to send some questions in as well. I have one specifically, Zoe, for you to start with. As pediatric providers, and I'm a neonatal provider, so my infants don't necessarily exhibit any behaviors that need to be flagged. How does it further sort of complicate the matters when we're talking about family members or parents?
Yeah, I mean, I think Julian could speak to this as well. You know, it's really just this larger question of what's the purpose of the note and, you know, who gets to be involved in the story that we're telling. I think it's really challenging for family members because you really are doing such a disservice to the patient if you're going to speak negatively about their family in a way, like in a flag that, you know, is ultimately going to be the first thing that pops up every time the baby's chart is opened. So I would say specifically, I think if it's family related, thinking about like a patient care plan type of note or something that's really much more collaborative in thought rather than any sort of label like this. So yeah.
I completely agree with Zoe. I don't have much to comment regarding flags specifically, but I'm not a pediatrician. I see older adult patients. The VA age mean is very high, but if I can make any comparison, we do see a lot of cognitive impairment and a lot of dementia. And there are a lot of family interactions, especially in the ICU, whereby that is our only source of discussion around goals and preferences and motivations for care. And we are as guilty of writing potentially stigmatizing and negative opinions about family members, and it certainly does a disservice. What I think, like, what to me was unbelievably powerful about Zoe's Dr. Kopp's example of the tragedy of the gentleman with the finger injury was just the power dynamics that are just throughout this entire note. And it was clear that he was powerless. And I think I try to be respectful, just at least thinking about these hierarchies when documenting, and I'm guilty of this all the time, but they don't have a choice, the families and the patients, of what we write in their notes. So I think this is just everything that Zoe just said. I think we need to reconsider what these notes are for, who even owns these notes, I think is a really interesting and important question.
Great. Ask your question, and then we'll just ask you both to restate them just for our Zoom audience, but one behind and then Naomi.
So excellent for pointing out all these. Curious whether you looked into how the documentation and use of this stigmatized language changed as the open note policy came into effect. Because I anticipate that the way we document it changed since they are now more readily available to access to patients. And I'm curious whether you looked into that.
Yeah, so
Repeat the question.
absolutely. So to summarize the question, how have open notes changed the language that we are using, especially stigmatizing language and biases, as a result of open notes and the Cures Act? I think it's Cures Act. Yeah, I think this is a really interesting question. I think it's a really great question, and I think we don't know. One of the complexities of studying this question is that just because open notes, there's a name for open notes, and it's about a decade old, even though it wasn't instilled at UCSF, I think until 2019, March 2019, I think. So the problem though is that it's not like notes were not available to patients before then, but the congressional acts changed how quickly they had to be available, and certain regulations around the ease to access. So the pre-post study is a very difficult one, but to answer your question directly, I think it depends on the specialty of the folks writing the note. This is not data-driven, what I'm about to say, but in my experience, the words and phrases that I am using in notes have not changed at all. Pre and post open notes, it's a little bit different at the VA. It was kind of always there, but my ICU colleagues, because I did, this was part of another study that is currently under review, other intensivists, in my experience, small sample, kind of said the same thing, that it really didn't change our practices. But when I speak to, let's say, my friends who are oncologists or radiation oncologists at these tertiary, quaternary institutions, whereby their patients are getting their fourth, fifth opinion sometimes because of the complexity of their care, they are exceedingly careful about the words that they use in notes since open notes came about. So I think if we actually studied this, it would be very heterogeneous and very interesting. There are other studies that actually show before it was instilled at UCSF or deployed at UCSF that there was a change in behavior, and then it kind of reverted back to the mean over time. So I think a lot of interesting questions. Yeah.
At that, patient behavioral flags are not a part of open notes, so they're hidden from patients. At the VA, they do let patients know that they've been flagged, and then the patient has an opportunity to try and get that flag removed. But at UCSF, we don't tell patients.
Thank you guys both for such interesting presentations. It strikes me that some of this is an individual framing, the way that an individual writing a note can think about their behavior is how the system. We'll talk about a lot of different things and a lot of different places where we particularly make changes. Could you reflect a little bit on if you actually one thing at the individual level that you ask everybody to do differently, and one thing at the system level that you think the system about this? Could you reflect on those things, just because there's so much very interesting stuff to talk.
I'll give them 1 second so I can share the question with the virtual audience. So Naomi mentioned that there's a lot of individual behavior behind what word am I choosing as an individual to write this note, but there's also systems level. How is the note used? Also, what is the system around note writing? And so I'm asking our presenters to reflect on one individual sort of action and one systems level action that our speakers would recommend?
Well, it's basically what I spoke about, which I think the three skills of reflecting language choice and remembering the power of writing can really be applied both as the note writer and as the note reader. So when I've done versions of this talk for medical education, we look at both sides, and it's the same skills for both sides of the coin. So I would say just trying to deploy those as an individual would be what I would recommend for the individual side. And then for the system side, I really believe strongly that we should very, very, very much limit the number of flags that we write. So UCSF just needs to make a policy that drastically limits their use and deployment. And the piece of that is that we need to tell patients that they're being flagged.
I just pontificate. And that was a joke. And Zoe is like the one who's actually doing the practical stuff. But Dr. Kopp is doing the practical stuff. What would I change? I actually look at the subjectivity in notes as a window into our own frameworks. So if they all disappeared, then I don't think I would have a research career anymore. But I think we should probably stop putting race in notes and ethnicities in notes unless we think it is truly important to the identity of the patient related and their family related to their health and their care. So what do I mean by that more? I think like maybe it might be relevant in social history, maybe still be a little weird, but I don't think it belongs in an HPI. I don't think these really belong in notes. And I think that we're headed in as a society, as a medical culture, away from including any race or ethnicity within our predictive algorithms. There's a lot of debate here. So that would be one thing. And then I think we should totally abandon describing and defining patients based on their disease. So describing patients as A or the diabetic or the cirrhotic, these are just like individual changes. But I think like okay, if I were to give any practical advice to myself, it would be, okay, if the patient were here reading this note that I am writing about them, would they be okay with it? And maybe that's what we should be asking ourselves, myself, when I am writing my notes.
We do have a question. Oh, one more question. We'll end with one from our remote audience.
My first experience with the flag was actually this past week. Years ago, into the room, I felt like made me change the experience. Go into that room, bias, going to reacting. But I actually, as a child neurologist, you know that a lot of my patients have intellectual disability. So I thought it was surprising that this was even something that was included. Because a lot of children with intellectual disability might have like inappropriate touch, like a lot might be very hugging towards me or inappropriately touch other things in the room. So I just was curious about flags for children and people with disabilities in particular, and what behind that. And then as a corollary to this, I think just as interesting as the information of word choice in notes, maybe the words that we avoid using with certain patients. And I find that to be very helpful because there have where certain words have been very provoking to certain families, and information generally
like not available in notes, and it's usually shared between clinicians verbally outside of the research inclusion of certain words that families do not being used towards them. Things like, this is very like sometimes families will say that they don't like when providers use certain terminology.
You bring up, so the question was about sort of flags or documentation for folks with intellectual disability or children with intellectual disability, and how there can be some helpful information, but in your experience, it really was not a helpful flag. And then the second question was around exclusion of words and sort of research around the words that we choose not to write rather than all the words that we choose to write. For the first piece, it's a great point. I think there's so many behaviors that are driven by medical illness, and many, when I did qualitative look at the flags written on patients in the outpatient setting, many of them make really no reference to the patient's medical illness, or they do, but then they criminalize, sort of this 85-year-old, who's delirious, and sort of describe them as a criminal for swatting, or a patient with seizures who has bizarre behavior after a medically induced seizure, and then has a flag written about them and ends up in restraints. So I really think that this type of documentation and language should be in a sort of like a care collaborative type thing. So I'm hoping that this EPIC upgrade will allow for the type of documentation that describes medical illness and potential behaviors that might be associated with it in a much sort of more patient-centered way. And then we can just get rid of these one-off labels after particular incidents that might no longer be appropriate. And I do not know of any research on the exclusion of language. Yeah, but it's a great question.
Sometimes that can be like a specific thing that changed the way that I interact with a patient to their better.
Yeah, I mean, I think that also could be sort of in a type of care collaborative note. And I think there's something to be said about the verbal handoff. There is certainly potential for stigmatizing language to be used verbally and biasing to occur from that. But there's something about the sort of teamwork approach that we're talking about a patient in real time and preparing to go in to see them, that feels a little bit better to me than the labeling.
All right, I recognize we're closing on time. We're gonna close out for our virtual audience, but I'm sure folks, if you still have questions, you can come up. But I'm gonna acknowledge my own complete lack of knowledge about AI in asking, because I didn't even know if this was a real question, but it came in and I can't wait to end with it, which is, do you know if the UCSF ChatGPT hallucinates as well?
Yes. Hallucinations are basically what we are defining as inappropriate or incorrect outputs that are untruthful. So facts that are incorrect. And yes, they do. There's a lot of work to try to prevent this.
All right. Thank you both so much. I know I've thought a lot about my own writing of notes and the language that I choose, and I know our audience has as well. So thank you.